This is the Eat Well, Think Well, Live Well podcast. I'm Lisa Salisbury, and this is episode 160, Midlife Metabolism, with Dr. Gillian Goddard. Welcome to Eat Well, Think Well, Live Well, the podcast for busy women who want to lose weight without constantly counting, tracking, or stressing over every bite. I'm Lisa Salisbury, a certified health, weight loss, and life coach, and most importantly, a recovered chronic dieter. Here, you'll learn to listen to your body and uncover the reasons you're reaching for food when you're not truly hungry, freeing you to focus on a healthier, more fulfilling approach to eating. Welcome back to the Eat Well, Think Well, Live Well podcast. I am so excited to be talking to Dr. Gillian Goddard. She's an endocrinologist and an adjunct assistant professor at Grossman School of Medicine. Did I get all that right?
Mostly, yeah.
Mostly? Okay. You correct me. Let's hear from you. Introduce yourself a little bit. Tell us about who you are and what you do.
Sure, absolutely. So as you said, I'm an endocrinologist and a professor at NYU. I also write a newsletter called Hot Flash, which is all about women's hormonal health, not just about menopause and perimenopause, but sort of everything from puberty through menopause. And I'm so excited to be here.
Great. Okay, well, as a lot of my listeners are in midlife, less of us in puberty. It's like, what do people call it? Like second puberty or
something like that. And sometimes if you yourself are in midlife, you live with someone in puberty. So there's lots of crossover there.
Yes, I'm familiar with that. I have two girls, so 17 and 20. So yeah, we are definitely in that crossover time.
Yeah.
So obviously, the main feature of perimenopause going into menopause is the hormonal changes. That's what causes all of the problems. So let's just talk about that, like a little bit of education on how those hormonal changes of perimenopause, like what happens generally. And then specifically, we want to talk about how those affect our metabolism, since that's, a lot of what we talk about on this podcast is weight loss and things that affect it.
Absolutely. So I think the best way to think about perimenopause is from the point of view of your ovaries. Women and girls are born with all the eggs that they will ever have. And from your first period onward, you are maturing eggs and ovulating approximately once a month, barring, events like pregnancy. And as we get typically into our late 40s and early 50s, the numbers of eggs that are left in our ovaries are starting to dwindle. In addition to that, the way our hormonal system works is the young, healthy, like best quality eggs get ovulated first. And so again, by the time we're in our late 40s and early 50s, not only are there fewer eggs, but the quality is lower. And the reason that's important.
Sorry, I'm going to interrupt you. The body just naturally chooses those? Like
kind of. It's more that they kind of raise their hand.
That's fascinating. I did not know
so
that.
To speak.
Which is why we're more fertile when we're younger.
Absolutely.
Because of the quality of the egg.
Absolutely.
Fascinating. Okay.
Absolutely.
Carry on.
So those old, low quality, last kids picked for the team eggs that are left in our ovaries in our 40s and 50s need a lot more hormonal drive to get them to mature and prepare for ovulation. And the hormone that does that is called follicle stimulating hormone, FSH. And so you need much, much more FSH to drive those eggs to mature. And FSH also tells the ovaries to make estrogen. And so what happens in perimenopause is you get these big spikes in estrogen and these big drops in estrogen. And that is a lot of what drives the symptoms that we are having during perimenopause and early menopause. And then as the eggs get even fewer, by the time you're down to, under 1,000 eggs, at that point, sometimes it takes so long to get an egg ready to go that the wires get crossed and you have a period without ovulating. That's called an anovulatory cycle. And sometimes you might go many months without a period because you're not ovulating because the eggs just can't get ready quickly enough and be ready to ovulate. And then finally, you run out of eggs essentially, and you have your last menstrual period, and the ovaries kind of start to say they're done and start to shut down. But our estrogen levels can still occasionally like spike up and drop even after our last menstrual period. And it is actually not the rising estrogen, but really the dropping estrogen that tends to create a lot of the symptoms that we have in perimenopause, the classic ones that people think of, like hot flushes, night sweats, and sleep disruption. But the other thing that happens is our estrogen levels drop and our androgen levels, those are hormones that we typically associate with men, like testosterone, our androgen levels oftentimes stay about the same. And so estrogen levels drop, but androgen levels stay the same. So the balance, the ratio between androgen levels and estrogen shifts toward androgens. And androgens promote weight gain in our midsection around our organs. Estrogen promotes weight gain around our hips, thighs, and in our breasts. And so we get this shift from a sort of weight gain more in the hips and thighs to this weight gain in the midsection. And that's super important for everything that happens to us metabolically after that, because it's weight gain in the midsection that changes how we metabolize carbohydrates, that changes, how well our body is able to use carbohydrates and how much insulin we need to use carbohydrates. It also has some effects on muscle mass. So on average, women lose about 1 pound to 2 pounds of muscle mass during the perimenopausal transition. And if you gain fat in your midsection and you lose muscle mass, you pick up some insulin resistance and you lose some basal metabolic rate. So your metabolism slows, you're burning less calories at rest. And when you consume carbohydrates, you're needing a lot of insulin to utilize them. And so they preferentially get stored in your midsection, which causes more weight gain in your midsection. And then you just end up on this vicious cycle where you become more insulin resistant, you gain more weight in your midsection, on and on and on, and until you break the cycle. Doesn't it sound fun?
Okay. Yeah. Oh dear. Okay. So I have questions.
Sure.
First of all, and this is actually just like a curiosity question, not really even on this topic. You said when you get down to under 1,000 eggs, I used to think, and I might be like, I was today years old when I learned this. I used to think that you had the exact, like the number of eggs and you released one per cycle. But I learned recently that that's not exactly true because I'm thinking 1,000 eggs, you still got plenty. Like that's a lot of cycles. But
That's
how
3 years or
typically,
something, right?
well,
More than.
more, yeah, way.
Yeah.
So how many eggs do you typically release? Because 1,000 eggs seems like still a lot left.
So most women start life with something in the neighborhood of 600,000 eggs, which sounds like you should be able to ovulate for like a millennium. But what
Yeah.
actually happens is a whole group of eggs start down the process of maturation. So at the beginning, you might have 50 or 100 eggs starting down this process, but over the course of the maturation process, many of them will die off. There's a chemical process that occurs within the ovary so that some of those eggs spontaneously, like they stop growing and they kind of just involute and get taken care of by the body's system for cleaning up old cells. So
Hmm.
that you end up with a dominant follicle, and that dominant follicle is the follicle that ovulates. So you only ovulate
Oh,
typically 1 egg a month. There are exceptions to that. Sometimes some women ovulate 2 eggs per month, and
and
that's,
that's how we get twins.
outside
One
of
of the
IVF.
ways.
Yes,
Yeah.
that's one of the natural ways we get twins. But most of the time, you ovulate only 1 egg, but many more eggs are starting down that process. So
Okay.
1,000 eggs is, enough to get you through 3 to 5 years, probably.
Okay. Okay, that makes a lot more sense because I was like, but how can you release more than one egg? We would have way more multiple births, but it's not that you release more than one. It's just that more than that there's a big okay, ghost. You
Yeah,
you heard her. I won't
yeah,
restate. So that's really just that's just interesting. I just like learning about the woman's body. So, okay, so my next question about this like estrogen versus testosterone balance is that we have seen a lot in, I'm sure a lot of my listeners are on Instagram and with a lot of menopause influencers. So there's a lot of push with hormonal replacement therapy, which I am on and I'm thriving on, especially progesterone at night. I love that. She's nodding. If you're not watching video, she's nodding along. So we can
hormone
talk about,
replacement therapy is fantastic.
okay. But why then is testosterone one of the things that I've been recommend? I've been
Yeah,
on and off of it. I'm
yeah.
I'm like mostly because I'm not sure I'm seeing the results for the cost, and because
Mhm,
my estrogen and progesterone are like basically covered 100% by my insurance, but
mhm.
testosterone, my doctor
It's not.
won't prescribe the male version
It
because
wouldn't be
that's an
covered by
option.
her insurance even if she did.
Well, it's just a lot cheaper than the
Yeah,
compounding
it
version that
is.
I have to
It is.
choose. Anyway,
Yes.
point being, it's a little bit of a cost for me. And
Okay.
so I have been kind of on and off about it. And but what I'm kind of paranoid about now that you've said this, and I just think people that might be on testosterone might think, well, why would I want to be on testosterone if that's going to cause weight gain around the middle? So how would that play into it? Why would we be, recommended to be on a testosterone replacement?
Yeah, I think this confuses a lot of people. So I will say a couple of things about this. Not everyone's testosterone stays the same in perimenopause. Some people's testosterone actually rises during the perimenopause and early menopause. Some women stays approximately the same, and some women's testosterone actually falls. And so if your testosterone levels are very low and you're symptomatic because of that, then adding testosterone may be helpful. That said, the only thing testosterone has really been studied for in women is hypoactive sexual desire disorder, which put
Mhm.
much more simply is low desire for sex and difficulty getting aroused.
Loss of
In
libido.
yeah,
Yeah,
not really wanting to have sex, and when you do, not feeling all that satisfied by it. And that's actually the only thing that testosterone has really been proven in the literature to do. But you're right, there's no testosterone that has been approved in a formulation dosed for women. And so your two options are compounded testosterone, which you get at a compounding pharmacy. The big challenge, there's two big challenges there. One is cost, as you mentioned, and the other is that compounding pharmacies vary a great deal in their quality control and reliability. They're not, the
sure.
way they're licensed is very variable. Or you can use testosterone formulated for men and just use really tiny
Really tiny
doses of
amounts.
it, which
Yeah.
it's messy and inelegant and not,
Yeah.
but I have lots of patients who do it because it is quite a bit cheaper. There has been talk about getting a product for women on the market, but I think we're a long ways away from that happening, partly because a
But
pharmaceutical would have to get behind it
yeah. Yeah. And a lot more studies done
and a
because
lot more studies.
so if someone were like, okay, but I do have, the loss of libido, it bothers me, I can't orgasm, I'd really like to try it. Are they risking midsection weight gain by using it?
Not if you're careful with the dosing. So one thing that can happen when you take testosterone is you can make the doses very high, so they're higher than like a typical woman's testosterone would be, and there you may get into trouble with side effects including some weight gain. If you're getting taking the levels and you're moving them from sort of low to more middle of the road for a typical female level, you don't tend to see weight gain issues with that. And
Okay.
the question is sort of why, right? Some of this is because there's other factors at play that we're just starting to understand around FSH and the role of FSH outside of the ovary. So I told you FSH tells the ovary to mature an egg and make estrogen. There's a growing body of literature, I think is the way I would put it, about FSH and FSH receptors outside of the ovary having potentially being related to metabolic changes we see in women in perimenopause. Because what happens to FSH in
Mm.
perimenopause and menopause is that it can rise very high. And so FSH may actually be acting in other parts of our body, including, in this case, importantly, the adrenal gland, to have impacts on our metabolism, our blood pressure, our cholesterol that are mitigated by that hormone directly and not by this mismatch between estrogen and testosterone.
Okay. So it's my understanding that menopause hormone replacement therapy, or HRT, or however you want to call it, is not a metabolism or weight loss fix. We don't get prescribed these things because we've gained weight. How, though, could they help in weight maintenance, or are they a factor? Because I've heard people say, oh, well, I'm going to get on HRT and try and lose some weight. And I'm like, those are two separate things. And yet our hormones are connected to our metabolism. So what role does that have?
So that's actually why people got interested in FSH as a potential mitigating factor with all of this to begin with, is
Mm.
people didn't understand if you give women back, the reason we don't use estrogen to help women in menopause and perimenopause lose weight is because it doesn't work. There's lots of data to show that it doesn't work. And
And it
so
works for
that's
a lot of
why
other things.
it
Like
works for, it's
it's
great for hot flushes, night sweats,
so great.
sleep, brain fog, muscle aches, joint pain. Your hormone replacement will help you with all of that. But it does not help women lose weight. And so the question was, well, why doesn't it? And and we think that this is where FSH comes into play, because when you take hormone replacement therapy, you do not typically suppress your FSH. So you don't typically get a lower FSH from taking estrogen. And so that may be part of the issue. However, I do think women who are taking hormone replacement for other indications sometimes see that their metabolic changes are less dramatic. And so they may not lose weight, but they also may not gain as much weight as the typical woman does in perimenopause.
Yeah. Possible, though, that that could be a correlation factor because people that are pursuing HRT are also those that are living, typically going to be living a more healthy lifestyle. They're typically the ones that are going to already be exercising and eating the things, and right. So it's a
And
confusing.
it is, and we don't have nearly enough, clinical trial data, like randomized clinical
Mm,
trial data around any of these issues, because for 20 years we didn't do clinical trials in perimenopausal women with hormone replacement therapy because of the
mm,
Women's Health Initiative. And so we're just
right.
starting to see those types of clinical trials really get going again. And so
Hmm.
all we really have are observational studies from the last 20 years or so, which you cannot sort out causation versus correlation with an
Yeah.
observational study, unfortunately.
And so, I mean, percentage wise, really, except for from what I understand, the last, handful of years, the percentage of women on HRT has been so low.
Between 2024, which is the year that the Women's Health Initiative study was paused, and basically women threw out their HRT on mass, like in a single day, because of the media coverage of the study.
Wait,
Between
sorry,
that,
not 2024 was just last year.
no, 2004, sorry.
So,
Between
okay,
2004 and
2004.
2020, sorry, I misspoke.
Okay.
So in those years
Hmm.
between when the Women's Health Initiative study came out and 2020, 4 to 5% of women were taking hormone replacement therapy. 80% of women have hot flushes and night sweats, and 4 to 5% of women were taking hormone replacement therapy. So when
That's
people talk
crazy.
about like, oh, we should be using it for this and that and the other, I'm like, how about we just start by treating the symptoms that women are having that we know it works for?
Yeah. Well, and another one I'm super passionate about, like all my friends know. I'm like, are you on vaginal estrogen though? Because
Oh,
everyone
yes.
can be on vaginal estrogen. And this is kind of off topic from what you and I are trying to talk about with, metabolism and these changes. But honestly, anytime I can plug that, like it's so safe, it's a microdose and
It's safe for women who have had estrogen receptor positive breast cancer. It does not affect breast cancer risk. It's
yeah,
safe for
like
everyone.
I just want you to say that again. Like we have an endocrinologist here telling us it is safe. It is
Vaginal
so safe.
estrogen is safe for everyone. We even now think it's safe for the vast majority of women who had estrogen receptor positive breast cancer.
Yeah. Okay.
That's
And
it.
why would a person want to use vaginal estrogen?
Because vaginal dryness is very common and can lead to a whole host of undesirable symptoms. When our vaginal lining and our vulva and the muscles that support our vagina and vulva don't have estrogen, they dry out. When they dry out, they thin and they stick together. One of my patients once said that her vagina felt like two pieces of Velcro being pulled apart when she moved. You can start to get atrophy, so you can actually start to get breakdown of the tissues and not be able to insert anything in the vagina, a speculum, a finger, a penis, if that's something that you're interested in doing. So sex can become very uncomfortable. It disrupts the flora, the bacteria that grow in the vagina, so you can get yeast infections. And then my all-time favorite is that the slumping down of the vagina actually pulls the anus and the urethra closer together, so it's easier to get urinary tract infections too, because you get bacteria from the anus into your urethra. So, and then
Yeah.
I mean, I could go on and on. Your
Yeah. I know.
uterus can press on your bladder, and
It affects
all,
the entire area down there. It's not just for vaginal dryness, although that is I've gotten to be almost so sensitive that because it's just a twice a week and so
yep,
I can tell like when it's time. Like
yep,
my body will tell me
yep.
it's
When it's
time, don't forget
time,
your dose today.
yep,
But even, if especially it is so cheap. So if you are having trouble like with intercourse and you can't do testosterone, like start with vaginal estrogen.
yep,
That will increase your comfort and to the point that you might solve your problem there. I mean, I don't
yep,
know, it depends on what your problem is, but if it's just a
yep,
comfort issue, start with vaginal estrogen because it's dirt cheap and
yep.
will really make such a big difference. So anyway, I just love talking about HRT. Like sometimes I think I should switch over to a menopause podcast, but um it just makes such a difference
Big
and
fan.
so, yes, we could talk a long time, but let's get back to like the metabolic changes that we wanted to discuss. So, we've got these metabolic changes and all of these hormones are kind of doing what they do in this midlife time, and we get that resulting change in body composition. So, we get a little bit more fat, a little bit less muscle. 1 to 2 pounds of muscle doesn't sound like a whole lot, but is this happening like every year we're losing 1 to 2 pounds of muscle or every decade? Like, and what can we do about that?
So the best data that we have around body composition changes and perimenopause really specifically looks at the 5 years before the last menstrual period and the 5 years after the last menstrual period. So a 10-year time with your
Hmm.
period, your last period is the midpoint of that time. And
Hmm.
so that 1 to 2 pounds of muscle is over that 10-year period.
Okay.
People do tend to lose muscle as they age too. So men lose muscle as they age, also not just women. It tends to be more gradual, but it only gets harder and harder to maintain muscle mass as we age because it becomes such a, again, like so many of these things, it becomes such a cycle because then if it's hard to use your muscles, then you don't use
Hmm.
them. And the less you use them, the less you will have. So, this is where, and I know everyone's talking about this right now, but this is where strength training is so very important for women in midlife because the best way to keep the muscle that you have and to keep the metabolic benefit of that muscle is to actively do things to use it and build it. The recommendation is at least 2 non-consecutive days a week doing 30 to 60 minutes of strength training. That can look like a lot of different things. It does not have to look like you in the gym pumping iron, although if you enjoy that, like it definitely works. I use Pilates as my strength training, and my instructor knows that my goal is to use it as my strength training. There's lots of different ways you can do it. You can use body weight, you can use exercise bands. You just have to be using those muscles. One of the things that's gotten very popular is weighted vests. There's zero data for that. I wish
It's so
I wish it
sad.
was so easy and that you could just strap your weighted vest on and go for a walk. There's no data that it actually works.
Yeah.
And it actually misses a really important muscle group, which is like your upper core and your arms. And I can't tell you how many little old ladies I've seen who slip and fall on the ice on their outstretched hand, and they break their wrist or they break their humerus or they break their shoulder, and a weighted vest isn't going to help you with that. So
Because you're not using your
because
upper
you're not
body to carry that.
you're right, you're not carrying the weight with your arms and your upper body.
So if anybody in my own neighborhood listens to this podcast, they're going to be like, but wait, we've seen you. I do use a weighted vest for a particular reason. And it is because I sometimes just want to go for a long walk and be out in nature because I enjoy that. And because, well, it's good for my dog. And I can't get my heart rate up to the point that I want it to be at.
Yep.
For the amount of time I'm spending. I don't want to just go for a leisurely walk and then have to also work out later. Like I want it to be my cardio for the day. And so I use a weighted vest to increase my heart rate. And so I just kind of want to like put it on my,
because
like a Post-it note. It's what?
You're like, don't think I'm strength training.
Yeah. I have done like, there's an old episode on my podcast about rucking, which is kind of like a little bit more like a lot more weight. I feel like that's probably a little bit different category than a 5 or 8 pound
than what you
weighted
usually
vest.
see people out like on your local like walking and running trail. Yes.
Right. So if you are using a weighted vest to increase your heart rate, go for it, do it.
Because
but
we
don't
know
pretend...
that increasing your heart rate is important, but it does not replace your strength training.
Yes. Yeah. And also, you don't wear your weighted vest to do deadlifts. Like it's not doing any good. Like don't do that. It's not, there's no use for it. Just lift heavier if you need more of a challenge.
Yep. Agreed.
Okay. All right. So the other thing I think that's confusing about these guidelines is when I'm in the gym lifting, I take the rest periods, right? It's like my program. It's like do these lifts and rest 2 minutes. But then I'm in there for, 45 minutes. All of those 45 minutes count towards this 30 to 60 minute recommendation, even though some of those minutes I'm standing around.
Yes, I know. It feels really weird to be like, it's a 45-minute workout and I didn't exercise for all of those 45 minutes. I think there's a certain like subset of us who are like rule followers and want to like get the gold star that we're like, that doesn't feel quite right. It is the guideline does not say you don't get to rest.
Okay. Yeah. Well, and I think too, a lot of us come from the little bit, cardio bunny, stepper rope. I mean, I started working out like my first experience with like regular working out was like step aerobics.
Right. Right.
And so, it's like you're working out the whole time.
Right.
And so strength training feels really strange when you've been doing that for a long, long, long time.
Yeah. Yeah. And I think some of that is generational. I think you and I are of the generation that was like cardio. And then like a year ago, we were like, oh, maybe we should strength train.
Yeah. Yes. So, okay, good. So yes, it feels like we know everyone's talking about this, but it's because it really is clear in the
Yeah.
research. Like
Yeah.
it's really clear
Yep.
for midlife women, strength training is key. And what's sad is you can't like not do your cardio though. Like I'm
That's
still
true.
doing those long walks. I'm still like
Yep.
in the pool. Still swim laps. Like so we just
Yeah.
need to balance our cardio with some strength training.
That's correct. We need cardio because I mean, it's really important for your cardiovascular health, for your blood pressure and, your heart. It's it's really important. And so yes, we're asking everybody to fit in an extra, yeah,
Yeah.
more stuff.
Yeah. Okay, so we're hoping that this sort of mitigates the weight gain, but it doesn't really work for everyone.
Hmm.
As far as some of us are still going to see some weight gain around this time. I can't tell you how many times I have seen a client who tells me like, well, I guess I would say I'm about half and half. Some of my clients come to me and say they struggle with their weight their whole lives, and
Hmm.
other clients come to me and say, I've never struggled with my weight until I turned 40,
Yep.
until I turned, 38, 45, all of just right in this mid-range. And so despite feeling like we're doing everything right, we're eating the fiber and we're, counting the protein grams and all of that, sometimes it feels like we're still gaining weight. So, what are the options at that point? What are we doing wrong? And, in the like what else can be done and what would you recommend?
Yeah, I mean, I think one of the things that's really tricky here is a lot of the patients that I see in my office, they're pretty well educated about their diet. There may be some changes that they can make, but there's not any low-hanging fruit. They are really
Mhm.
doing the work. And for a long time, we were taught, this is literally a board question on the endocrine boards, that if a patient is not losing weight, if they create a caloric deficit, it means that they're miscalculating their calories or lying or eating more than
Mm,
they think they are. And in my experience, that answer should be wrong. It's not.
mhm.
That's supposedly the correct answer. But there's so much more going on that we don't understand about weight that isn't calories in and calories out. And genetics are a huge component. And metabolic syndrome, and we used to say, well, weight gain causes metabolic syndrome. It's becoming more and more clear that weight gain and metabolic syndrome are caused by the same thing, that is probably an interaction of our genes with our environment. And so I think, sure, if you're eating poorly, then changing your diet can be really helpful. And I do think sometimes people are eating a lot more starch and carbs than they realize they are, and a lot
Mhm.
less protein and fiber than they realize they are. And so making that shift can be helpful.
Yeah. And starting a food journal, this is like, I preach on this all the time. Like,
Yeah.
just start writing it down. Like, you don't even have to have an app. You don't have to be entering and calculate, like weighing and measuring everything. Just write down what you're eating. It'll give you a really clear picture of like, oh, yeah, I really didn't eat a vegetable today. You don't
Mhm.
need to weigh and measure all of your bread to notice that there wasn't anything green.
Yeah, I agree with you. I actually track my intake daily in a very casual way. It's just, I had, I don't know, I can't even think. I had a salad with chicken for lunch with that's it. Like that's the whole
Hmm.
entry. Salad with chicken.
Hmm.
It's not
Hmm.
more complex than that. But it does. You look back on it and it makes you think like, oh gosh, like I'm really missing protein today. I should really focus on getting some protein in on my snack or my dinner or what have you. It does raise your awareness. It's not judging. Like it's
No.
just information. It's
Yeah.
not, I think sometimes people feel like that you're being very like punitive about it. It's
Mhm.
just data to help you
Totally.
make good decisions.
Yeah. We can't make any changes until we see what's happening currently. We
Yeah.
can't possibly know what to do
Yeah.
if we don't know what's currently going on. So,
Yeah.
yeah. So
Yeah.
that's for starters, but carry on with some of your other ideas.
So there's a couple of different things that people have done over the years. I think that medications in general have been underutilized, although I think that pendulum has really swung in the last
Yeah.
few years. Now, I would argue medications are probably overutilized. But if you are someone who is following a healthy diet, and what is a healthy diet? A diet that is low in refined carbohydrates and simple sugars, high in fruits, vegetables, fiber, and lean proteins and healthy fats. It doesn't have to be more complicated than that either.
Right.
There's no like right diet. It's more of a concept. But if you're doing that and you're exercising and nothing is happening, or perhaps you're even gaining weight and you're getting told that you have high blood pressure or you're pre-diabetic or your cholesterol is rising or you have fatty liver, which are, I mean, all of these metabolic changes that can come with midlife, this is really where I start to think about medications. And until fairly recently, we didn't have a lot of great options. But in the last 10 years, we've had GLP-1 receptor agonists. So, I mean, this is Ozempic and Wegovy, and
Hmm.
Mounjaro and Zepbound are slightly different, but kind of fall under the same umbrella. And the newer ones, the Ozempic, Wegovy, Mounjaro, Zepbound, are much more effective than the older ones. But the concept of using these medicines for weight loss is actually not new. It really didn't start with Kim Kardashian.
Right.
Endocrinologists have been using these medicines for weight loss for more than a decade and off-label for probably close to 2 decades.
Yeah. Well, GLP-1s as a class were invented, I think, 20 some years ago.
The first GLP-1 was approved in 2005. It was called Byetta. It didn't do much for weight loss. It was a diabetes medicine. And
Hmm.
the reason you don't hear a lot about it is because it was a twice a day injection. So it was hard to even
Oh,
get
heaven's
diabetics
sakes.
to use it.
Yeah.
Um,
Goodness.
But not long after that, in 2010, liraglutide was approved. That's Victoza and Saxenda. It was approved for
Hmm.
diabetes in 2010. People were using it for weight loss basically from the minute it was approved, and it actually got a weight loss indication in 2014. So this
Okay.
idea is not new.
Yeah.
It's just been very widely adopted.
Yes. Which leads us to, yes, they are excellent, very useful in midlife. Lot of combinations that we're seeing, like you're on hormone replacement therapy and you're on a GLP-1, can be very helpful for midlife weight gain, as opposed to someone who suffers with the disease of obesity who will likely be on a GLP-1 for their entire life. It's my understanding that those that struggle with just some midlife, like just in the last couple years, might be able to use it more short term.
Yeah,
Yeah.
that's my experience too. I
Okay.
find that, you know, the people who really got some midlife weight gain and maybe it crept on and they kind of, I feel like I see this woman a lot. She comes in, she's maybe early 50s, and she almost didn't notice at first that
Hmm.
it's so insidious. It's like a couple pounds, a couple pounds, a couple pounds
Hmm.
until you've gained 20 pounds.
20.
And oftentimes those women have healthy habits, or by the time they get to me, they have healthy habits. They've already seen someone to help them with their diet. Those women in particular, tend to do quite well with GLP-1s, and I often have my patients come off of them. The one exception to that is women who had gestational diabetes and then have started to
Mm.
develop some blood sugar changes in midlife. A lot of those women tend to need to stay on GLP-1s longer term, not for weight, but for blood sugar management to avoid
Mm.
getting diabetes. And they have been proven to significantly reduce your risk of getting diabetes if you're pre-diabetic. Um,
So, and that's an interesting feature about GLP-1s. It's not just, they don't just work by suppressing your appetite. There's other things, as the layman in me is going to she'll tell us what the other things are. But there's other things that they do to help with the metabolism. Is that correct?
Absolutely. So I actually think that the appetite suppressant effects are some of the least important things that they do,
Mm,
especially for people who are already following a fairly healthy diet. They will reduce intake, particularly at first, because you just feel full faster and you stay feeling full longer. But they they make your body more sensitive to insulin. And
mm,
insulin as a hormone doesn't just, so its main thing that everybody thinks of it for is that it helps your cells take up sugar from your blood. So it helps keep your
hmm
blood sugar normal, and it helps your fat cells and muscle cells take up sugar and your liver. But insulin has signaling in your brain, in your satiety centers. Insulin tells your brain that you're hungry and that you want carbohydrates. And so if you can reduce insulin resistance, you actually see your central drive for hunger and cravings reduced. It also changes what you do with sugar when you do consume it. So when your insulin levels are high, you preferentially take up sugar and store it in your midsection as fat, which we've already talked about is particularly bad for us from an overall health perspective.
hmm
And instead you're able to utilize that carbohydrate for like physical activity for your brain. And so you're not needing to consume carbohydrates. You're not on this roller coaster of eat carbohydrates, they all get taken up by my midsection and turned into fat, and my blood sugar drops, and then I feel hungry and I crave carbs, and then I get back on the roller coaster. So it really
hmm
helps you even out those blood sugars so that you're not constantly feeling the need to consume those carbs just to kind of maintain, to keep yourself feeling okay. And the roller coaster feels crummy. So a lot of times people say they feel so much better when they're on these medicines because they didn't even realize that they were on that sort of roller
hmm
coaster ride from the minute they started eating when they got up in the morning. So it also slows gut transit times, not just out of your stomach, but into your gut, and how carbohydrates get absorbed from your gut into your bloodstream. And all of those things have significant impacts on why they work. They've actually done some studies. I actually think nobody ever talks about these studies, but I really like them. So anytime you make a drug that blocks a receptor or turns on a receptor, so in this case, these drugs turn on a receptor. They act like the hormone GLP-1, which is a hormone we all have in our bodies. They act like that hormone and they bind to these receptors. Anytime you make a drug that works that way, one of the potential downsides is that the cells just start making more of those receptors. And so they've actually
Oh,
looked
yeah.
at the
That's
body and looked at different tissue types to see how they respond to GLP-1s. And our gut does upregulate our receptors. So when you start taking a GLP-1, you might feel really nauseated, you might get really constipated. Then the receptors upregulate. So there's more GLP-1 receptors and those side effects go away. That's also why sometimes people panic because they aren't getting that real big sense of fullness anymore.
okay.
But then when they look at the brain, in our brains, the receptors don't change. And so all the
Oh,
effects around satiety in the brain and cravings in the brain are not changing,
and the
even
food
though,
noise
yeah, the food
feature.
noise is
Yeah.
amazing. Yeah.
Yeah. So that's why the protocol is to continue to go up in dose because the receptors increase.
The protocol is to continue to go up in dose because when you do, I'm not a big fan of the protocol.
Oh,
When you do a clinical trial, your goal is to show that the medication is as effective as you possibly can in the shortest possible time, because your goal is to have the data that you need to go to the FDA and say, look, our drug works, approve us so that we can start selling it and making back our money.
mm,
Pharmaceutical companies are for-profit businesses. There's no doubt about that. And so when they did these trials with both Wegovy and Zepbound, they had very strict protocols around up titrating the dose. And if you couldn't tolerate the up titration, you were out of the trial essentially. And it was because they wanted to get the
Wow.
biggest effect possible in a reasonable amount of time. I actually think people can titrate up the dose much more slowly, and we would see a lot fewer complications with these medications if people did. I usually only increase the dose if people aren't losing about a pound a week, depending on patients' side effect profile. So if
Okay.
someone's losing more slowly than a pound a week, or they're having a lot of side effects, we may decide to increase or not increase the dose based on that. And so I have patients who are on very middling doses who have done incredibly well without going on a very high dose.
Because
I think
there's another feature of pharmaceuticals, which is to use the lowest possible dose to get the effect that you want, which
Mhm.
really, although that doesn't make the money and get it to the FDA very quickly, it is the safest route. Yeah.
Yeah, I mean, I just think that if you are getting the desired effect,
Hmm.
why would you increase the dose? It just doesn't make any sense to me. All you're going to
Yeah.
do is get more side effects. You're not
More side effects.
necessarily
Yeah.
going to get a bigger effect. And in real life, we are not limited to the 72 weeks or whatever it was that most of these trials were.
Right.
You can be on these medicines for an unlimited period of time for as long as you need them. And
Hmm.
so, you read about all the horrible side effects that people are having, especially vomiting. I always tell my patients, if you're vomiting, I want to know about it. You can be nauseated. You should not be vomiting, because that is a
Yeah.
sign that you're increasing the dose too quickly.
I had a client that finally quit because of the vomiting, and I just felt so bad because I couldn't do anything because I'm not the
Right.
doctor,
Right.
and I'm like, "Okay, but
Right.
you shouldn't be vomiting. Like, don't
Yeah.
do that. We got to do." And finally they just quit the
I
medication,
know. I
which,
mean, that's what I
they
worry
still lost
about.
weight.
Yeah. I feel like the patients who are really sensitive to these medicines, honestly, often do really, really well because they're very sensitive to them, and we don't need to
Yeah,
ratchet up the dose for them to get the
so
desired
much. Yeah.
result. So,
So, as with any medication, there are people that these are not right for. And so,
contrary to popular belief.
yeah, there, I've seen some videos of some people that are like, I think in 10 years, everyone will be on these because they're good for everything. Like, probably not good for everything, but who should not be considered a candidate?
I mean, I really think these medications are for people who are struggling with weight gain, struggling with overweight and obesity, who and and I would even add, and are starting to see the have metabolic effects that are associated with obesity. Those are the people who these medicines are intended for. And those are the people
Hmm.
who have been studied in clinical trials with these medicines.
Hmm.
The people who should not be on these medicines are people who are looking to lose a modest amount of weight, or sort of more vanity purposes.
Hmm.
Look, I mean, I think there's lots of us out there who, grew up in diet culture and feel like we could always lose another 5 pounds.
Hmm.
These are not for that. I also think that one of the things that it really concerns me about people who are using these medications inappropriately, women in midlife who are using these medications inappropriately, is that it really, being too thin leads to problems later in life too.
Right.
And so people who are thin and frail also have health problems. They may have different health
Hmm.
problems. And so I worry that people are, you know, going to be trading one thing for another. And we need to
Hmm.
recognize that there's a point at which being thinner is not better.
Yeah. Yeah. Perfect. Okay. This has been so good. So good. It's been delightful talking to you. I just love talking to medical professionals that really just know what they're doing. So thank you so much for sharing
Oh,
your wisdom. So why don't you
oh,
tell
it's
us more
been
about, I know you have a Substack. We'll put the link, but tell us a little bit about that, where people can find you online.
Yeah, absolutely. So I have a Substack called Hot Flash. It is not just about perimenopause and menopause, it's about all women's hormonal health. We talk about all different kinds of things there, and that is at savvypatient.substack.com, and we'll make sure to get you that link. And if you like what you read there, stay tuned because I do have a book coming out in spring of 2026 where we will talk about all things related to women's hormonal health and not just estrogen and progesterone, but like all the hormones. So
Oh,
I think
okay.
it's going to be really great.
Awesome. Thank you so much. And yes, we'll put those links in the show notes. So thanks again.
Oh, thanks so much for having me. It's been really fun.
If this episode hit home for you and you want support working through your perimenopause or menopause symptoms and weight gain, I'd love to talk with you. I have 2 free resources right now that I know will help you. Download the What to Do When You Overeat course if you find yourself overeating too many times in a week to see lasting weight loss. You'll get the Reset and Recover guide and figure out how to reduce your overeats and not beat yourself up about it. Or you can grab my brand new GLP-1 Success Starter Kit. This is for anyone already on GLP-1s, or maybe you're just GLP-1 curious, but you don't have any support or structure around what to do. Your doctor knows how to write the prescription, but she isn't equipped to support you day to day, and that's what a coach does. You can also schedule a free consult session to see if my one-on-one coaching programs are right for you. All the links are in the show notes. Remember, it's not just about the food, it's about empowering yourself with choices that truly serve you. Have a great week, and as always, thanks for listening and sharing the Eat Well, Think Well, Live Well podcast.